Thank you very much. This is great. I think what's instructive here is that in the northern latitudes, municipalities normally have contracts for snow removal, even if it doesn't snow, right? But when it snows, there's already a contract in place so that the plows are out, within hours of there being enough snow to plow. Sometimes it works better than others, but this is the procurement method, and it's an advance contract where everybody knows where the money is, how it's going to be paid, and the contractors know what they have to do. So that's sometimes, because I think it's not as common in the health sector, in the responses to emergencies in the health sector. So thank you very much. I think we have finished with the panel inputs, very rich inputs into this workshop, and we would like to ask for questions from the audience, and on any, it's a very vast and complex topic, so anything goes. In setting the stage, has anything been missed? Do you have any reactions or suggestions for how we can think about this framing going forward? So, do you see anybody? Yes? Okay, but please say your name and then also which panelists you would like to address.
My name is Victor Bampo. I'm from Ghana. I have, it's a comment. It's not actually a question. I think thank you very much for these very rich comments. I enjoyed all of them and I learned a lot. I'm particularly troubled because maybe this is just the beginning, but it seems like there's an over-reliance on the financing bit of things. And I think that we must calibrate things properly so that we, between prevention and management, and then the responsibility between the donors and the recipients is also properly achieved. And I'll tell you why I'm saying this. For me, there were 3 essential failures when Ebola hit. The first failure was a failure of diagnosis. So in Meliando, in Guinea at that time, there had been a cholera epidemic and everything was geared towards cholera. And they missed it. The second was a failure of social mobilization. So at the time when the messages were supposed to be going out to bring people to get treatment, the messages were about a very dangerous disease that you were likely to die from, so it drove people away. And then the third was the failure of the international response, where the funding and so on didn't come in time. I'm the Deputy Health Minister in Ghana, and the difference between countries like Ghana and Liberia and Nigeria and some of the other countries where this happened, in my estimation, was the preparedness of the health system. So I think that at least there must be enough focus on strengthening the health systems to the point where we would not need to do as much emergency mobilization. And I think that at the very least there should be that kind of balance so that while we talk about the resources when things get bad, there's so much that we can do to prevent it getting to where it got to in the first place. Thank you.
Yeah, great comment. Thank you very much. The workshop is on the finance, and the title is Financing, but it's very much depends on how is the framework, how are the policies in place to govern the use of that financing, and the system strengthening in advance is definitely is the most productive investment that's possible on behalf of mankind, according to Larry Summers. So that's clearly what we should also find ways to ensure that financing actually flows to the preparedness. Somebody else? Sorry.
Good morning, everybody. This is George Gao. I'm from China CDC. because we are talking about international collaboration here. I myself, I think Richard Gregory is here as well. I spent 2 months, September to November, years early on. So I know a little bit about what happened on the ground. So when we are talking about international collaboration for financing response, from this outbreak, I found the coordination and leadership there on the ground is very important. Even you have the money, you have all these logistics, and Dr. Botru mentioned something about you have a list. So if you didn't have very good, coordination and leadership, even you have goods and logistics there, it still stay, resting on the ground. So what I thought, so tomorrow we are talking something about, I was asked some experience from China CDC and some priority. One of the priority for the international collaboration here, we need, in my opinion, to reestablish the confidence from the developed country for the developing country. The thing is, for example, when we were in the ground, there are a lot of goods in the airport, city airport, from the Red Cross, but it's delayed to distribute to any region. It's urgently needed, but the goods are sitting there. So there's no laborers and no people there, all this stuff. I think we need for when we are talking about international collaboration, who will be the leader, WHO or whoever, but we need someone, to coordinate whenever we have an emergency. Thanks. That's my comment.
On somebody has to be in charge. I think it was the comment, and maybe Jordan wants to elaborate.
Yeah, I just want to say a couple of quick words. First, to the last gentleman and his comment. The issue around coordination, I think there was good coordination within a month after the public health event of a public health emergency of international concern was declared. I think the problem was it should have been declared much earlier. And the reason that is that the scale of which the epidemic was racing was really on an exponential rise. And it took weeks after the PHIC was declared before you actually had the kind of leadership in country that could actually help the emergency operation team that had come together to really reach the highest levels of government. And that sort of happened really in late August, where the team that was actually responsible for the response actually could reach the presidential offices in each of the 3 countries, make decisions without going through multiple layers of government, and really make mistakes, adjust, and continue to try and make decisions that would result in the response. And so the thing about coordination is we need to have some kind of system in place that allows a public health emergency of international concern to actually be triggered earlier, whether it's a lower level kind of response or whether the threshold for declaring these needs to be lowered and taken out of the political influence, because it really should have happened 6 to 8 weeks earlier, and the scale needed to catch up wouldn't have been so grand. And then the gentleman from Ghana who spoke, your first thing you said was a failure of diagnosis. I think that's actually a critical comment. I think there are 2 things that the international health regulations and the global health security agenda are trying to address. There is clearly a need for improving the clinical care services, throughout the region, but there is a critical need to improve the public health infrastructure so that there is a resilient public health system in place. And that requires a national laboratory that is receiving specimens from roughly 80% of the nation all the time, practice doing competent testing, that there's surveillance, looking for syndromic illness. And believe me, throughout these countries, there was plenty of opportunity to see deaths among healthcare workers in clinics that should have triggered a surveillance system to send specimens for testing. It shouldn't have had to wait so long. And then there needs to also be a workforce that's trained. And because there was no workforce trained and no surveillance system in place, there was no notification that we need to send specimens, and there was no specimen sent or placed for the testing to be done. And that is the failure of not having a resilient minimally effective public health system in place that the IHR asked for and that all nations under the UN umbrella committed to back in 2005. Thank you.
Following up then from Jordan, I have a question both for the Minister here and Mr. Beck.
Muting. Most people say that'd be a good idea if I was muted. So question for the Minister and also for Mr. Bertrou. What Jordan's talking about really is surveillance. And we're talking a lot about mechanisms for financing, if you will, in the simplest way, putting stockpiles of cash or letters of credit or whatever in a bank ready to go the moment there is an issue. But in order to assure maximum return, that such mechanisms for financing actually do good, you need to spend money now on improving surveillance. Lately, I've heard a lot of talk about, oh, we should have a healthcare system, surveillance system like weather surveillance. The thing is, of course, weather surveillance, they spend billions of dollars each year on weather surveillance. They still don't get it right? But they have the funding. We're nowhere near billions of dollars. We're not even near hundreds of millions of dollars every year. So here's the question for you gentlemen. How do we get the funds spent today to improve the surveillance system so that we can actually go to areas up front and actually unfold these funding mechanisms you're talking about so they actually do some good in ameliorating the next pandemic?
That's a tough one. We'll solve it tomorrow. Can I, Maris, can I say?
Good morning. My name is Maris Pierre-Louis. I used to be the public health cluster leader at the World Bank before I retired last year. And I have a question for the Vice Minister of Health in Mexico. Could you comment, sir, on the multi-sectoral collaboration that you were able to put in place to have an effective and swift action in the case of MERS in Mexico? Thank you.
Okay, if I can react to the question from our representative from CDC and then to the collaborative care, just very quick. The issue about surveillance is very similar to everything we have in the health system related to preventive care. We just don't respond until we have a problem in our faces. Surveillance was actually a very important lesson in the Mexican case, because late response has a lot to do with late awareness of cases. Now, I think, just trying to complicate things, there's not one recipe in terms of financing. Of course, it varies from type of epidemic, from the response capacity of the country, and from the stage of preparedness or the stage you want to really reinforce. The mechanisms for financing, which are on the pre-level, have a different logic than the ones you really want to enact during the response, which is the critical period. And then there's another stage of financing, which is the reconstruction or the aftermath. And I think the different mechanisms and the different institutions have different comparative advantages to addressing the financial needs of each stage. I think what is really, really poor is the emergency response capacity. That is the most critical and what I think needs a lot of working. The pre and the post, I think, have been addressed. I think the World Bank does a really good job. And in terms of the preparedness and the surveillance systems, I think there has to be an awareness strategy coming from the international organizations and a lot of capacity building, because things don't happen just because it's not a funding issue. It's just that the concern is not high enough on the public agenda. And of course, it doesn't show on the public agenda. It doesn't get the funding. And with respect to the international collaboration, if I understood it right, I think for the Mexican case, especially what happened between March and April 2009, was a very, very close collaboration with PAHO, WHO, and the Mexican health officials. And everything was pretty much decided in coordination with them. So it was no coincidence that the declaration of emergencies were taking place at the same stage, at the same time, because things really took place in a very well-organized fashion. So I think, regardless of whether it was the right time to do it, it could have been earlier, it could have been later, and what the consequences in the economic part were, the collaboration was essential in terms of getting the right credibility in the local media and in the local scenario. Many countries, it was the case of Mexico, the criticism was very large of having overreacted to the pandemic, especially once it was found. It was so unpredictable. Once it was found that the virus was not as threatening as it was previously thought, of course, came the criticism. One important thing that was there to argue was the collaboration, that everything was consensus or was done in very, very close talks with international authorities, basically WHO and PAHO. I hope I answer the question. If
No, just a clarification. I think I wasn't clear enough. I meant the multi-sectoral collaboration within countries between trade, tourism, defense, agriculture. How did you put this together in order to mount that effective strategy to address the epidemic? That's what I meant.
Okay. First of all, it's important that the deciding body that was put in place in the Mexican case was headed by the president. So that helps in terms of getting everybody collaborating. Second, there was very little information on the implications. So yes, there was a concern about basically economic activity, tourism, closing down the schools, which took place soon after the 25th, was a very debated and complicated decision, but everything, let's say, was consensus within the cabinet at these emergency meetings that were taking place, chaired by the president. So I think that at the very beginning, most of the decisions are basically decisions on the public health emergency part, and eventually the implications come in place later on. And if you don't have leadership at the highest level, especially when it concerns the collaboration of different sectors, the things will get very complicated.
If I might just add one thing. I think there was two sets of comments that I just wanted to make sure that they were threaded together, because I think they're rather an important point. There was this comment around there is this problem of political will to move rather early, when that's exactly what we need to do within these emergencies. And I just wanted to tease that out a little bit. And I think there's a bit of a scarlet letter for a lot of countries in pulling that trigger of an emergency too soon. And at some point, we have to understand, well, what are we actually trying to get out of it? And there is this issue, I think, at the end of the day, what we're talking about today, I don't think we should walk out with, well, what's the one thing on the financing that must be done? I think there's probably more than one, and we should be comfortable with that. And it's largely because there is a need for systems financing, absolutely. And those need to be deployed immediately, irrespective of emergencies. But rightly said, there probably needs to be multiple triggers. There needs to be, call it a pre-emergency evaluation trigger, whatever is the case. Things that do not have that scarlet letter attached to it, such that framework agreements are in there that can move resources quickly. And if it's irrespective of whether or not it's a budding emergency, move resources to answer questions immediately. Then there is this other construct of if triggers are actually hit for the bigger chunks of money to move those resources in a bigger way, and then the recovery that happens afterwards, rightly said. But I think we have to put ourselves in the mindset of the minister who's realizing, I need to build my systems, which is completely different from I need to be able to mobilize resources for the evaluation without setting off a panic attack. And those are real things that are going on, and I don't think we're realizing that. Even though we're saying we need to react faster, there's a competing thing that says, let's not react too fast because there's a there's a scarlet letter there.
Milan?
Hi, I'm Milan Brambat, also formerly of the World Bank, where I worked a lot with Olga on economics of pandemics. I think a lot of the questions or comments that are coming up are really touching on the fact that there are two levels or two main tasks that are coming up. It may be helpful to kind of be clear about those two, which are quite distinct in some way conceptually and in terms of the financing streams in institutions. One is the building of public health systems in developing countries, and the other one is the international coordination and emergency response. I think Mexico was lucky in some respects that it's an upper middle income country with a well-developed public health system. But in many other cases, West Africa and Ebola, most clearly, such systems hardly exist. Now that task is a long-run development task. The kind of institution building, the kind of long-term financing streams that are important there may be distinct from the other task, which is building a very effective, quick response international system. And that's, of course, essential because pandemic response is a global public good. So it's economically efficient for the world to share some of the costs of doing this. It's inefficient to simply leave it to the developing countries on their own to build these systems. So I think that's, I'm not saying anything that hasn't actually been mentioned by most of the speakers here, but it may be helpful to clarify these two levels of tasks, two streams of funding and two types of institution building that may be necessary in doing this.
Thank you very much. I mean, it is two different conceptual problems, but they're also connected because if there's little preparedness, little surveillance, we are bound to have much higher response costs and much higher financing needs for those response costs. So it's not either or. Doing more of preparedness and prevention lowers the burdens of the responding and the illness and the crises that unfortunately we see when the preparedness is not there. But it has been very difficult to arrive at higher levels of prevention for many reasons. But we'll try to, that will be tackled tomorrow. Yeah, can you want to follow up?
Just wanted to add something. Thank you very much for your responses. I think very fascinating. I just wanted to make a quick point that when Dr. Zhao was speaking, he said something that struck me. He said we need to learn now before memories fail, and that's actually what is happening now in some of our countries. So, for example, in Ghana, the U.S. has been very generous, together with other countries, Canada, Norway, and so on, giving us resources. But because Ebola has passed or is passing, then I spend all my time fighting fires, and Ebola is not one of them right now, but there are resources that we need to use to help strengthen IHR. So what kind of incentives can we put in place to make sure that the resources that are already available are used for what they're supposed to be used for? Because now I have the US saying I have $13.1 million that you can use to do all the strengthening. Frankly, it's difficult to get some of our people in the ministries focused on doing it because it's not an emergency as we speak now. So sometimes I think my point is that it's not just about the money in the bank, it's about going through the whole process to make sure that it's sufficiently and properly utilized for what it's supposed to be used for.
I might just add a quick response. I don't have all the answers, but I'm certainly close to one. I think that the international health regulations, only about 30% of countries have thus far, even through self-assessment, reported that they're compliant. I think we need independent assessments of not only international health regulations, but also independent assessments of these investments, such as the Global Health Security Agenda and the monies you just referred to. I think if there are independent assessments of these systems, there's the original fear that, oh, I'll look bad. But that shouldn't be the point. The point should be, where am I falling short? Because now there's, at least in the short term, because of Ebola, because of attention, there are at least monies available to address the shortfalls and try to get these systems built and in place. So That's how I would answer that question. On medical service delivery and other aspects, it's a larger scale problem. But on public health systems, I think, having independent assessments, calling for independent assessments, looking at the shortfalls, getting them fixed with these resources now is what's needed.
If I might just add one thing, I think all emergencies are different except for one thing. There'll be more that come in the future. And at the end of the day, even though the money and the resources is not as important for you now, it's thinking about putting the systems in play to actually tap them when they do come, because they're going to come. And I'll give you a couple of examples. Some of the countries that piloted this idea of leveraging the private financial markets had this question about can they legally tap these funds if necessary? And it required, at times, a review between the Ministries of Health and the Ministries of Finance. There was a ministerial meeting that was being hosted by the African Union and the Global Fund, and lo and behold, both the Ministries of Finance and Ministries of Health were actually invited, but there was surprisingly no Ministers of Finance ended up showing up. It was nothing but the Ministers of Health. So they started asking each other, how do I win that resource fight with my Minister of Health? And one camp was just thinking through, when you're talking about winning the fight against the Minister of Energy that says, if I don't get funding, you don't have electricity in your hospital. If the Minister of Agriculture that says, well, if we actually had money in people's pockets, they can actually take care of themselves instead of going to public hospitals. How do you do that? That was one camp. And then this other camp that said, well, if I can't win the fight of getting more resources, what about the right policies and systems? And so some of the ministers that had used these resources talked about, and Senegal is a perfect example of this, they actually did a legal review and evaluated their ability to use these private financial markets and wrote an opinion paper, basically, that said, leveraging guarantees and short-term borrowing under 12 months is approved as part of the national procurement modality. Now, those are the type of preparedness things that one can do to be able to move quickly at that next emergency that will eventually happen.
Okay. Yes, over there. Yeah.
Hi, my name is Adam Bornstein, and I'm from the Global Fund. I just wanted to bring something up regarding the donor aspect. And specifically, most donors have mandates that are given to us by the donor governments or by the UN or whomever has actually organized the donor, the organization. And in a lot of cases, these mandates prevent us actually from using our funds and our systems in place for these pandemics and emergencies. And so one thing that would be really helpful is to discuss ways to kind of put a blanket mandate clause into some of these kind of structures that would allow for some funding to be channeled immediately. Because the donors, and I speak Global Fund and other groups, we have programs on the ground, we have capacity, just that we can't transition into these areas without that mandate. So it's a little building off what Aaron said, and maybe going a bit further. So.
Can you explain a little bit about the mandate that's lacking for what exactly?
Sure. So, for example, with the Global Fund, we're a $30 billion development fund that focuses on TB, AIDS, and malaria, and that's where we stop. So if there's an issue with Ebola, it's very difficult for us to sort of transition into that area because we're focused on prevention and treatment of AIDS, TB, and malaria. But we still have billions of dollars in our portfolio in our bank that can be channeled to different areas if we were able to do that within reason. So that would be one example.
The management of the Global Fund proposed such a scheme? I mean, such a action during a dire emergency? I mean, you would have to have it approved
we
somewhere.
can talk about that later.
Right?
Yeah. I mean, we have gone through the process and looked into that, and so I can talk about that a little bit later on this afternoon during one of the sessions.
Okay. So the idea is that there is a large pot of money that's public funds, essentially, and it could be temporarily or permanently channeled somewhere else?
It's not.
Okay.
Yeah, we can talk about it a little later.
Tomorrow.
Sure. Just a question, particularly for Captain Tapero. I mean, I had the opportunity to see the U.S. response, the U.S. military response in Liberia, and it was indeed really quite impressive. I mean, and hats off to the U.S. government for doing that. But when looking at it, one had very much had the impression it was based on a military principle of an overwhelming response. And so when we think about this from a finance perspective, I'm kind of wondering, was anybody in all of that activity standing there and saying, could we be doing this cheaper? Could we be doing this more cost effectively?
Yeah, again, I think it would certainly have been cheaper if it would have happened earlier, and we wouldn't have needed something on the scale of a Department of Defense from, with the logistical and air transport and communication support systems that had to be brought to bear. So that's the first answer. The other answer is, I think, again, if the emergency had been declared earlier, it might have been possible for the medical NGO community to scale up using local resources to build local Ebola treatment units with simple materials. I mean, these facilities are not high-end. They're plywood floors, they're plastic sheeting. What you need is PVC piping, you need chlorine, you need simple systems to build these standalone ETUs. And I think that, again, if it had happened earlier, there would have been enough of a reserve among the medical NGO community to handle that as they have in the past. But the scale got too big. And I think the Department of Defense's response, what it was it was so big that it also brought other governments to be big. And we needed to be fast and we needed to be big because we were losing at an exponential curve the race. I think there have been comments about the projections put out by CDC in late September that if we really don't have some kind of an exponential response, then this exponential growth curve is going to lead to over 1 million cases by January. And what that response needed to be was to stop 70% of the transmissions. And I think that because of the global response, I mean, that finally happened. And it also happened because communities started to realize themselves that the community resistance around unsafe burials, they started to see for themselves that it was destroying their community. So some of the community messaging and the resistance to traditional burials started to turn the corner. Burial teams went from 4 to like 68 over a period of 6 weeks because resources were there to pay people, train people, equip people to do safe burials. And I could go on and on down this cascade of why all of a sudden, things finally turned. And I think that response in Liberia was then shadowed in Sierra Leone, so that by December, when Freetown was under the same kind of siege that Monrovia was in early August, there were actually ETU beds in place, and even though there were way too many hotspots all over the place and infections with community-wide transmission happening, at least the contact tracing teams, when they would go out, find someone who was a known contact of a case, they actually had a place to send them. And Monrovia didn't have that. And so what happened in Monrovia was those individuals saw that there was no place to go when they went to the Ebola treatment unit. They went back to their home village, for support and care, and it just had hotspots happening all over the country, and you had every district in the country eventually with ongoing chains of transmission. So we got ahead of it, not just because of the ETUs, because of the contact tracing teams that could get out there, community acceptance of we have to do some kind of isolation even if in the absence of ETUs, and that started to turn the tide on the curve, or bend the curve in the slowing it at least.
Jordan, can you also explain something about where the budget came from? For the response, which was quite, it was a high, costly response. So how was the budget found? Where?
Yeah, well, I'm not a budget expert. I'm an epidemiologist, so take this with a grain of salt. I think early on, the Centers for Disease Control, we have an emergency operations center. It's activated by our director, and our staff get pulled into that response. And it's been the largest response of our agency internationally in our history. We've had over 1,300 people deployed to the field. We have about 150 people across those 3 countries now. We actually have people in many of the countries that are adjacent helping to do preparedness work. We've also had over 2,000 people working in our Emergency Operations Center headquarters supporting those deployments to the field. That's a huge lift and a strain on our agency, and the resources that came to bear on that come from the structure of our agency for emergency response. And then I think early on for CDC, I can't speak about the rest of the U.S. government. I can say a few words about OFTA, but for the U.S., I can't speak about all of the resources for the U.S. government. But for CDC, there was about $30 million that we had available to us in the early months, and then as publicly known, in middle of December, the President's Emergency Request Fund was acted on by Congress, and over $6 billion across the U.S. government for Ebola response and global health security, of which CDC received about $1.8 billion, $600 million for our domestic preparedness response, as well as $1.2 for global health security agenda and our ongoing response in the affected countries and highly at-risk countries nearby. The issue for us was no longer by December, do we have money to respond? It's do we have the mechanisms? Can we get the partners? Can we get the procedures? Can we deploy? And we worked very hard at that. The Office for Foreign Disaster Assistance, once declarations were declared in the 3 affected countries after the public health emergency of international concern was declared on August the 8th, also provided resources for OFTA in the 3 countries to start funding partners to do all kinds of work, such as funding burial teams, et cetera. The challenge was, again, and I said this earlier, was by that time, it was so late in being called that the medical NGO community that we normally turn to, whether it's earthquake in Haiti or the earthquake in Nepal or floods or tsunamis, normally the medical NGO community comes out in great numbers that it's often hard to have enough resources to fund them all, but the need can be met because there is such a willingness to contribute. In this case, it was so frightening to people that calls to foreign medical teams went unanswered, medical NGOs left instead of stayed, and other medical NGOs that were pleaded to come were resistant to come, and it took quite a while for them to come to bear. But by then it wasn't the money, it was fear because it had just gotten so out of control. I really do think that, whatever criticisms there are about military responses, MSF was calling for it. They were right. It brought incredible confidence back to the fight, and the NGOs came back, and that was what was needed. We needed a multinational response. We had to address the concerns about fear. We also need the payment of the locals. They're truly the heroes. No training, stepping forward and coming to work and doing contact tracing and doing direct patient care.
Oh, that's okay. You can. No, we no.
Yes, so I'm Tore Godal from the government of Norway, and I don't think we have a problem with regard to rapid disbursement because we have a safeguard of money for humanitarian action. And we then, in this case, gave it very rapidly to Red Cross, to Doctors Without Borders, and to WHO. Now, that may create an inefficiency in terms of fragmentation, which I think would be useful to have assessed in this context. With regard to the Global Fund, we fund Global Fund, we fund Gavi, we fund UNICEF, we fund World Bank, we fund WHO. We don't want to see that they deviate from their mandates because they have a mandate to solve a particular problem. And in this case, and I illustrate the point, it was a herbalist, as you know, that brought the Ebola epidemic to Sierra Leone from Guinea. And you could not have said whether that person had malaria or Ebola or something else or malaria-resistant Ebola. And so I think in terms of building a surveillance and response mechanism in these countries that must be able to attack multiple tasks, I think the Global Fund has a very important contribution to make. And if I understand, in Uganda, when the outbreaks have been very small in Uganda, at least partly, it is because of the network of bikes that the Global Fund have for supporting, for testing newborns for HIV/AIDS transmission, and this has been used for early detection also of Ebola. Thank you.
Thanks. I mean, that's very practical. Thank you very much. I think we have run over a little bit our time. I'm sorry, and there'll be a break.
No, there's another session.
Right away. Oh, sorry. There is no break. There's another session.